Hi, everybody. Thank you for joining us. My name is Angie Wright. I am an EMS physician at the University of Colorado Hospital. I'm double boarded in emergency medicine and in EMS. Medical director for our pre-hospital program and also for the city of Wright EMS, which is how Steve and I know each other. Do medical direction for some of the Eastern I-70 corridor and some of the other areas in kind of the northeast area of the state. I started Reese. This is our second year, so we're pretty excited to be kicking this off. And some of this is brought to you by a regional grant, specifically looking at how we can improve access to information for our EMS providers who are sometimes far away from where the concentration of resources are. So with that, we bring you the Rural EMS Education Series. We have changed the way that we are giving CEs. So at the end of the slideshow, there will be a QR code that you need to scan. And then Steve, correct me if I'm wrong, but you scan it, you fill out a couple things, and then you get your CE certificate delivered to you immediately.
Yeah, so it brings you to the site. You fill out your name, your scope, agency, and I think that's it. Hit submit, and it's like literally instantaneously your CEs are in your email box. Oh, in your email address. Yeah, gotta have that.
Yeah, right. That's how you get the CE certificate, which is great. If there are any issues with that or with the system, please email Ryan Shelton. I will put his email in the chat, uchealth.org. And he can help you if there are any issues. But again, there will be a QR code at the end of the presentation, and that way it just automates the CE certificate to go directly to you. We cut out the middleman. You get your CEs right away. Really good question, Trevor. And I know this has come up. Steve, do you know the answer? If people are on their phone and there's a QR code, how do they scan their QR code if they're on their phone?
Let me email Ryan real quick and see if we can get a link that we can put into the chat.
Great. I love that. If you just want to text him, that's probably going to be the fastest yield. And you can do that while I start talking.
Yeah, I'll do that. Here it goes.
Great. Thank you. All right. Well, we will kick it off. Please ask questions in the chat. Please feel free to unmute yourselves and ask questions. These are more fun if people chime in. I am going to stop my video because some of you have seen me present before. I have a fun party trick, which is when I talk in front of a group of people, be it in person or virtual, I will break out in hives. So I'm going to spare you all that experience. My video will be off, but I'm watching the chat and we will be going from there. I'm going to record. I am recording. Am I recording? I'm already recording. Oh, I think it's doing that automatically. Great. And then, oh, Marissa has a good idea. Screenshot the QR code and then email it to yourself, and then you can take a photo. And we'll also work with Ryan about getting a link. So I love this problem solving in real time. So what we're going to do is talk a little bit about shortness of breath tonight. And Steve and I are going to tackle this topic together. This is in no way comprehensive, but we're hoping to go over some important considerations, not only for just the general topic of shortness of breath as a presenting complaint for someone who calls 911, but also some considerations for prolonged transport times in our rural EMS providers, because sometimes if someone comes in short of breath and you're 6 minutes from a hospital, that's very different than if you're 45. So our learning objectives for tonight, we're going to recognize the various pulmonary pathologies that might lead to respiratory emergencies. We're going to discuss infectious and non-infectious causes of shortness of breath. We're going to understand some key pre-hospital interventions in the management of patients experiencing shortness of breath. We're going to do a little refresher on how to clinically recognize respiratory emergencies and discuss some of the unique challenges of shortness of breath in the rural EMS providers. So One of the things that I've noticed in moving through kind of primary EMS education and teaching more for our paramedic program is sometimes what we need to do is change the way that we approach a problem. So it's one thing to be able to just kind of sit there and read the textbook or read the article and think about a chief complaint or a pathology the same way it's always been taught to us. But what I hope to do tonight is actually to kind of break this topic up into a different categorization in order to create kind of some new wirings in your brain and new ways to approach this problem. And I think in doing so, it helps us take common topics and look at them a little bit differently and figure out if there's different ways we can approach this in the field that will allow us to take more efficient and better care of our patients. So one of the ways that I like to think about shortness of breath and just an approach is the anatomic location. So you're going to see a variation of this image throughout our presentation tonight. And the variation of this image will kind of highlight where we're talking about in the airway. We are primarily going to be talking about kind of the lower airways and the lungs for this presentation. But remember, when we talk about shortness of breath, it can be a problem from anywhere up here to anything along the way. And so think about anatomic location of where the problem potentially is. And then I think about whether it's an air problem or an oxygen problem, if it's a blood flow problem, or if it's a structure problem. So is it an air problem, a blood flow problem, or a structure problem? And is it if it's air, so we're talking about oxygenation and ventilation, is it an in problem? Is it a problem of getting air in, or is it an out problem, a problem with getting air out? We're going to spend quite a bit of time on the out problem today. But just keeping in mind that one of the ways we can, when someone says they're short of breath, kind of thinking through it as where is the problem? And then is it an in or an out problem? Or is it a blood flow problem? Or is it a structural problem? So we'll do things case-based because I think that's a fun way to learn. And it is more interesting than me just sitting here talking for the entire time. So case number one, this is going to be an out problem. All right. So you're called to the home for a 19-year-old female who has difficulty breathing. And when you arrive on scene, you do your primary assessment. You can honestly even just do this from the doorway, right? She's sitting up on the couch, sitting upright, leaning forward, hands on her knees. So kind of in that tripoding position. Her airway is intact. She has audible wheezing. You can hear wheezing without even using your stethoscope. She has accessory muscle use. So that means she's using the muscles around her collarbones. She's using all of her intercostals or the muscles in between her ribs. And she's using her diaphragm and her abdominal muscles. So all of the muscles around the thorax are also being used. And you go up, introduce yourself, palpate her radial pulse, and she is tachycardic, but with a strong pulse. So looking at this right away, the question is then going to be, what are we going to do next, right? You've got a partner with you. You have this doorway assessment from a sick, not sick standpoint. We can say right away, based on what we see, that she is sick. So we are very much trained to do A, B, and C. Her airway is intact, so we're going to attack B right away. So what are our next moves? And I want you to start thinking about what your next moves would be. Well, you may want somebody to get a set of vitals for you, right? So here's your vital signs. She's got a heart rate of 110, a respiratory rate of 25. Blood pressure is 130/80. Pulse ox is 95%. Her end tidal is 45, temperature is 37, pupils are fine, GCS is 14, and she's a little bit pale. So we're gonna get a little bit more history of her, right? So she's a 19-year-old. She says she has a history. Well, her parent roommate rather says she's a history of severe asthma. Her roommate came home and noticed that she was really short of breath and dyspneic. She was feeling okay throughout the morning, and then throughout the day, she started to feel worsening chest tightness after she cleaned her room. She used her rescue inhaler a few times. Her symptoms then rapidly progressed, and she developed the wheezing, the difficulty speaking, and that was when her roommate called 911. Dispatcher was astute enough to say, stay calm, sit in a position of comfort, and then that is when you arrive. She's allergic to dust and cleaning products, so maybe made a not great choice with cleaning her room today. And Did your screen just lose my slides, Steve?
No, you're good.
Oh, weird. Okay. Allergic to dust. And then, as we mentioned, she's got all of the intercostal retractions. Everything else on her exam is pretty non-revealing. So my question for you guys, and feel free to throw stuff in the chat or unmute, is what is your next priority? Got a pretty good history here. We're suspicious that we probably know what the problem is. Maybe we throw her an end-tidal inhaler. Yep, have her use her inhaler. Consider setting up a nebulizer. Is her inhaler expired? Good question. The 5 rights, right? If you're going to help her use her inhaler, you want to make sure that there's still medication in it and that it didn't expire. So double checking those things. For agencies and levels of providers that have end-tidal CO2, and yep, considering other, I like, what is happening?
Now it's gone.
Now it's gone. All right, that's all right. We can problem solve this. Stand by. We are all thinking about what we would do next as I bring PowerPoint back up because PowerPoint just crashed on me completely. Yes, Alex, get her out of the room that is causing the problem. Yep, that is a great, great solution, right? Getting her back into the back of your ambulance. If her triggers are cleaning products and dust, and she spent the day cleaning her room with cleaning products, then we probably should remove her from that area. Nope. And share screen. Share. Slide. How we doing, Steve? Back on?
Good. Keep going. There you go.
And there we go. All right. So here we are. We're removing her from the room. I love that idea. And then for the providers that have end tidal within their scope, there's a little shark here, and then a picture of what might be a shark fin end tidal waveform. Not as dramatic in this picture as I have seen in real life, but keeping in mind that your end tidal waveform can really help you differentiate what might be going on. So here's that picture that we talked about. We're going to be talking about the lower airways as we are talking about this case. And we're going to talk a little bit about obstructive lower airways disease. So COPD, which we'll cover in a little bit, but then asthma, which we suspect our 19-year-old with a history of asthma and this trigger is probably suffering from. And so remember that for obstructive lower airways disease, what we're really dealing with is an out problem. We're having a hard time getting the air out of the lungs because as they exhale, the walls of the airway end up pinching closed. What does this look like clinically? Well, your patient might have pursed lipped breathing. This is my 8-year-old. She's trying to demonstrate what pursed lips breathing looks like for you guys. But essentially having those pursed lips. And why are they doing that? Well, what's happening is that they're trying to do what's called kind of auto PEEP, or they're trying to provide a little bit of back pressure to the exhale phase of when they're breathing that will kind of prop open or stent open those lower airways. So because what's happening as we exhale with asthma, the airways are collapsing on themselves. By providing a little bit of back pressure, we're hoping that rather than having kind of a suction effect where the airway collapses, we can actually stent open those lower airways. So patients will try to do this on their own through pursed lipped breathing. You'll have an increased I to E ratio. You may hear this term, and what we're talking about is an inhalation to exhalation ratio, essentially. So remember, if it's an out problem, it's pretty easy for the patients to breathe in. They can breathe in pretty quickly, but then they have a hard time breathing out. And so it's this long E phase of their breathing. So they have a quick inhale and then a long exhale. abdominal muscle use, which we talked about, and then you may or may not see jugular venous distension. Why do you see jugular venous distension in patients that have obstructive airways disease, such as asthma or COPD? Well, the reason for that, remember, is that the thorax, the chest cavity, is very pressure dependent. And so if you're trapping air in your lungs because you can't get it out, what you're doing is you're increasing your intrathoracic pressure, the pressure inside your chest. And as you're increasing that pressure, it makes it harder for blood to follow its normal track. And so it might get a little bit backed up. So you can actually see JVD from the air trapping that's causing an increased amount of intrathoracic pressure. So these patients, the problem, as I mentioned, is getting the air out of the bronchioles. So in mild asthma, what you can see is you're starting to get these changes. So you've got this outside wall is your smooth muscle of the bronchioles. And then you've got a couple other cell layers, and you're getting some mucus formation, but you still have a decent amount of area here to be able to inhale and exhale. What happens in chronic asthma, and that we'll also talk about with COPD, is you actually get airway remodeling. So over time, the anatomic structure of the bronchioles will change. And so you can see here that you're going to have increased fibrosis. These muscles are thickening. You have more mucus. You have kind of this scar tissue and inflammation in here. So now it takes very little to set this into a crisis mode for your airways. So whereas here you have some room for inflammation and swelling to occur, here you really don't. A trigger can really cause these to collapse pretty quickly. So as these airways get narrower and narrower, it gets harder and harder for us to get air out. This is not something that I would expect you guys to memorize, nor do I want you to memorize. This is actually our in-hospital protocol to how we deal with a patient that has asthma. And the reason that I put it in here is that asthma, as we kind of astutely picked up on in the beginning of this case, is something that it abides very well to bundled care. Meaning asthma is one of those things that as soon as you're like, I am pretty sure this is asthma, really following the protocol and the algorithms is going to be successful. And this is because it's a disease we've known about for a long time. It's a disease we know what the best practices are for management. And so it's not an illness when we see it in the field that we need to get particularly creative with. We don't really need to think that much outside of the box when it comes to asthma. And we'll go through some of these different treatment aspects to kind of go through what works and what doesn't. But the reason that this is here is that it's really just a illness that we understand well enough that it lends itself very, very well to bundled care. So what are some things that increase the risk of asthma-related death? And these are the questions that we ask our patients that are suffering from asthma, right? So have you ever been intubated for your asthma before? Have you ever woken up in the ICU is sometimes how I ask that question. How many times have you been admitted to the hospital this year? How many times have you been on steroids this year? These are actually really important questions to get, and especially as a pre-hospital provider, if you're dealing with a sick asthmatic and you're concerned they're going to continue to deteriorate, trying to gather this information up front can be really, really helpful to the hospital side of things, because knowing kind of what their previous trajectories have been can help us anticipate what we might see in the future. So knowing if someone's been intubated for their asthma before means they have really, really bad asthma. And those are patients that I get very nervous when I start to talk to them. They're not going to know if they had respiratory acidosis, but again, just kind of as a risk factor for an asthma-related death. And then again, additional admissions and multiple steroid bursts. And then if patients have 2 or more episodes of a pneumothorax, so you can actually get the big blebs in asthma, you can get spontaneous pneumos, because as you trap more and more air, it can cause a pneumothorax. So asking these questions up front is helpful. And we'll review a couple of common definitions here. So pretty common, I'm sure we've heard of the term asthma exacerbation. And asthma exacerbation is defined as acute or subacute episodes of progressively worsening shortness of breath, cough, wheezing, and chest tightness. This is an asthma flare and asthma exacerbation. And that's the majority of the patients that we are going to see in the pre-hospital space and in the hospital setting. So it's acute or subacute, they're just gradually getting worse. But if the exacerbation escalates, if things start to get a lot worse, which scares, I think, most of us, then we can define it as status asthmaticus. And status asthmaticus is an extreme form of an asthma exacerbation. And this is when things really start to go off the rails. So status asthmaticus is defined by an asthma exacerbation that then has hypoxemia, so low pulse ox, hypercarbia, so they'll have that potentially elevated end tidal, and then secondary respiratory failure. So this is when we should start getting pretty nervous that things are about to hit the fan. And status asthmaticus is defined as severe asthma that is unresponsive to repeated courses of the beta agonist or the standard albuterol inhalers. So this status is when again we start to get a little worried. So a couple things to think about. The inhaler isn't helping. So then what do we do? And that's what we talked about and Alex brought up in the chat. Is there an infection we need to be thinking about? Is there a trigger? Are we still in an area that's causing the reaction to occur? Do we need to change locations? And then some signs that your patient is in status asthmaticus is they are struggling to move air. They're using their accessory muscles. They have a hyperinflated chest. They have inaudible breath sounds. And this is important. I know we always think of asthma as wheezing, but those airways that we looked at that can close off, that get narrower and narrower, can get so narrow that you actually can't move any air in or out. And if that's the case, you're not going to hear breath sounds. Not hearing breath sounds on a patient that has asthma that looks as sick as our patient looks is a big red flag that we need to get treatment started very soon. And then if a patient is exhausted, severely acidotic, and dehydrated. A tired asthma patient is a scary asthma patient. So someone who is too tired from working so hard that they can't keep up with their compensatory mechanisms anymore is a patient that is about to fall off the cliff and become respiratory and be in respiratory arrest. So a patient that's in status asthmaticus should be working hard. They should be sweating. They should have elevated vitals. They should be tachycardic. They should be tachypnic. And if those things start to go down, then know that you're getting ready to have a problem on your hands. And so a question in the chat about the kind of the line between someone having triggered asthma versus status asthmaticus. And I think that the textbooks do this a couple of different ways, but the easiest way to kind of think of it from a definition standpoint is that if you have tried repeated doses of a beta agonist inhaler, be that or nebulizer, and they aren't responsive, then we would define them as being in status. All right, this is worth just taking a glance at. And I don't know if anybody has asthma that's on the call. You certainly don't have to share with the group, but that more and more pulmonologists and primary care doctors are teaching asthmatic patients how to take their own measurements at home. So either their peak expiratory flow, which is what this is, or their FEV1, their forced expiratory volume in 1 second. Basically, what this is telling us is how well they are getting air out and what zone of what they should be in, and that determines how severe their asthma is at that time. So based on height and weight and size, patients should have a idea of what their predicted peak expiratory flow is, and then you can determine kind of what that percentage is. This is not something I would expect you guys to calculate in the field. It's just something to be aware of as a way to kind of classify how severe their asthma is. It is something that more and more we're seeing patients going home with devices to learn how to take these measurements to figure out what they need to do. Okay, so the good news is we do have some decent medications to treat asthma and status asthmaticus, and there's some that are just standard and some that go a little bit outside of the box, despite needing this to be protocolized care. So we're going to cover those, but what we're going to want to do in the mainstays of our drugs for asthma is to decrease the inflammation, relax those smooth muscles. Remember those muscle cells that we showed around the airways? Those are all really tense and contracted in asthma, and we want to relax those smooth muscles. And we, of course, want to improve oxygenation and ventilation. I don't know if you guys are familiar with this meme. It's when Oprah's like, you get a car, you get a car, you get a car, everybody gets a car. So what we're saying here is everybody that calls 911 and has an asthma exacerbation gets some version of albuterol, some short-acting beta agonist. So albuterol and levoalbuterol are the two most common that patients will have at home and that we will carry in the ambulance. Everybody gets it. You can get it as an inhaler, you can get it as a neb, you can get it as a continuous nebulizer, or you can get it as every intermittent nebulizers, but everybody gets albuterol. You're going to give 2.5 to 5 milligrams of albuterol for a neb for mild asthma, and up to 10 milligrams of albuterol for severe asthma in a nebulizer form. This is how it works. We don't have to memorize this, but we do want to know from the pharmacology standpoint. So again, it's a beta agonist. So what we're doing is we're promoting this receptor to go into its nice little shaped home. That's going to create this cascade of things that at one point in our lives we had to memorize, but we don't have to know anymore. So you turn the switch on, all of these great things happen, and you get airway smooth muscle relaxation. So beta agonist, meaning the medication is activating this beta 2 receptor, and then it goes through and causes airway smooth muscle relaxation. For our ALS providers and critical care providers on the call, I heard this recently from our pharmacist, and I really wish someone would have taught it to me, a decade ago. But getting beta 1 and beta 2 straight, you have one heart, you have two lungs. So beta 2 receptors we find in the lungs, and they're beta 2 agonists for our asthma treatment. So there's a little fun little way to remember that. Okay, so everybody gets albuterol. Also, almost everybody should get steroids. So steroids take time to work. They take a while to kick in, and they're incredible anti-inflammatories, but the sooner you can get them on board, the better patients do. And that's what our studies tell us, which is why we have incorporated them into a lot of pre-hospital protocols, because if we can get steroids as soon as you guys get to them, then those may be working by the time they get to the hospital, or at least a little ways into their hospital stay. So earlier is better for steroids. Prednisone is a pill. Most agencies do not carry PO prednisone. Some do. And a lot of our ALS agencies in Colorado do carry methylprednisolone, which is solumedrol, which is an IV steroid. So the sooner you can get these on, the better. They decrease the overall inflammation, because remember, we have that kind of perpetual inflammatory cycle going on. All right, so albuterol, check. Steroids, check. And then we have our inhaled anticholinergics. This is ipratropium bromide. This is the most common one in the field. So often you'll hear the duo-neb, right, which is albuterol and ipratropium. This is a bonus, not a substitute. So you really need to give this in addition to that beta agonist. This does not stand alone as a particularly helpful medication. It works as an acetylcholine antagonist, which further relaxes those smooth muscles of the airway. So again, a bonus, this is the second half of your duo-neb, but it's really that beta agonist that we want to see in asthma. Is it a bad idea to give anyone who is wheezing solumedrol, or should they only be given? I don't think it's a bad idea. I think if your suspicion is high that there's, an inflammatory process, whether it's asthma or COPD, even bad pneumonia, if your suspicion is high that there is an inflammation happening in those airways and that's the cause of their wheezing, then I think solumedrol is a very helpful medication. One dose of steroid is not going to be I mean, nothing is ever 100% of medicine, but for the most part, one dose of steroid is not going to be catastrophic to a patient, whatever their underlying issue is. So I think that one dose of Solumedrol is appropriate for the wheezing patient, especially if you suspect an obstructive cause. All right, so these are a bunch of names of other medications that you don't need to know that are inhaled anticholinergics, but just to point out again, that ipratropium or the Atrovent. So we've got our inhaled beta agonist, we've got our albuterol, right? We've got corticosteroids, so Solumedrol, and your inhaled anticholinergic, so your ipratropium or Atrovent. So what are we going to do now? These are our 3 pillars. You're going to get 2.5 to 10 milligrams of albuterol and 125 milligrams of Solumedrol. Okay, so we did all those things, Dr. Wright. We did all of the things you told us to do, but the patient isn't better. They're still wheezing. They're still working really hard. We did our Oprah treatments, but she is still working. How long has it been? So this is a question that's debated in the literature, which is kind of how long do you give these things to work, and when do you start escalating in your algorithm? And I think this is especially important to consider in the rural setting and prolonged transport times. You know, if you've given your albuterol, do you give it 5 minutes? Do you give it 20 minutes? Do you give it 30 minutes? A lot of algorithms in the hospital say reassess them after 1 hour. Now, if your patient's critically ill, that's not sufficient. Definitely should be sooner, and you're going to be making these decisions in more rapid succession. So we do talk about this first hour of care, but I think you have to keep in mind that I wouldn't, if your patient is still extremely ill after 5 minutes after you've given them these medications, then it's time to start moving down your algorithm. Now, again, steroids are going to take up to 1 hour to work, so you're not going to see that right away. But if your albuterol isn't working and your patient is still working really hard, then we start getting a little more creative. So a lot of our pre-hospital protocols have magnesium in the asthma algorithm, and this actually has some decent literature behind it in that it reduces morbidity and mortality in severe asthma exacerbations or in status asthmaticus. So magnesium is probably not going to help your patients that just have like run-of-the-mill asthma exacerbation from a little virus. They need a couple puffs of albuterol, they're doing better. Mag isn't going to help them at all. But what we're looking at is our sickest patients, and that's what we're talking about here. So magnesium works because it's an antagonist at the cellular level, and it basically blocks calcium. So we're going to just get a little nerdy and a little cellular for a second. Calcium acts at the cells, causes smooth muscles to contract. Magnesium goes and fights it at that receptor and can cause smooth muscles to relax. So again, we're trying to get those smooth muscles that surround the airways to chill out and to relax, to open up that track. So that is the idea with mag. You're looking at 2 grams over 20 minutes. The nice thing about magnesium is it's fairly harmless. I think that statins should be in the water. I think we should be able to nebulize Ativan, and I think that everybody should get 2 grams of mag. Kidding on most of those, of course, but mag is a fairly harmless medication. If your patient is not doing well, just go ahead and give the mag. It can cause weakness, hypotension, flushing. I feel like I'm on one of those commercials listing out all the side effects if you slam it in. And we do recommend, if you're giving mag, to give it with IV fluids. Epi's a good medication. It's a good medication for
And you're really
yeah.
muffled.
Oh, really?
Yeah, just like all of a sudden.
Is it just to Steve or is it to everybody?
You what?
Everybody else. Yeah, it's a Steve problem.
Oh God. Here we go.
Thanks, guys. Look at this chat participation. All right, I appreciate everybody saying that they can hear me. Sorry, Steve. All right, so let's move into Epi. Epi is a great medication for a lot of things. If our patient is still not getting better, then we can add on Epi. I will say the evidence isn't great here, but the science makes sense. So subcutaneous or intramuscular epi, because remember, epi also works at that beta receptor, right? It's the beta 2 agonist at low doses. And if we give it systematically, we can imagine that it's also going to work in the lungs. So it's shown that it does its job. It works at that beta receptor, but it's not actually as good as our albuterol. But again, if our patient's getting sicker and sicker, we need to consider this as an adjunct. You would give epi for severe asthma either IM or subcutaneously, and it's done at the same dose as we would use for anaphylaxis, so 0.3 milligrams of epi. Of course, please follow your local protocols. That is always the caveat with these things, but epi in asthma makes sense scientifically. You do need to remember that our patients that are really struggling to breathe are going to have tachycardia, and they're already going to be hyperadrenergic, meaning they're already going to be making a lot of their own epi. So in patients with cardiac issues or illness, you need to be careful giving it. But with epi, you're usually going to see the benefit from a respiratory standpoint within 5 to 10 minutes. So it's a fast acting medication. If it's going to work, you're going to see very quickly that it's helping. All right. I don't know if anyone's seen this movie. It's from Anchorman. And when he's sitting here, he says, well, that escalated quickly. And that's what we feel like when we're sitting at the, head of the bed on this asthmatic patient and these interventions, and we're going down our algorithm. We're talking about giving epi. Maybe you're calling base. Maybe you're calling your med command to say, there's a sick asthmatic. They're starting to tire out. I'd like to try epi. But as we move down our algorithm, things get less and less scientifically beneficial. So now what about CPAP or BiPAP, right? Non-invasive, wow, the picture's blurry. Non-invasive positive pressure ventilation. So interestingly, almost all of the studies for non-invasive positive pressure ventilation, so CPAP and BiPAP, have been done in COPD. And while COPD is a similar process to asthma, there are some differences. So we've extrapolated a lot of those studies and said, well, if it works in COPD, then it should probably also work in asthma. They have similar but not identical pathophysiologies, but most major guidelines do incorporate non-invasive positive pressure ventilation for a critical asthmatic. A lot of the studies they did where they just tried to look at this in asthma just didn't have enough people to say that it was a good idea. But similar to epi, the science makes some sense. And intubating an asthmatic should be avoided at all costs. And we'll talk about that in a second. So if you've given them MAG and you've given them their 3 pillars and you've given them epi, I think this is also worth a shot if the next move is going to be trying to meet up with a helicopter or intubating the patient yourself. So where do we start? Again, if you're initiating CPAP, you should be starting around 3 to 5 centimeters of water, which I think is pretty standard. You don't want to be giving them too much positive pressure because it's an out problem. And with CPAP, and we'll go into this a little bit later, but you're giving that constant positive pressure. So you want to make sure you do have an opportunity for the patient to exhale. And then if you're initiating BiPAP, you can see, again, a theoretical benefit, but your EPAP at 4 to 8 and your IPAP at 4 to 10. And then no PAP because we don't actually know. But one of the things that non-invasive positive pressure can do, both theoretically and practically, is decrease the overall work of breathing on your asthmatic patient. So if your patient's getting tired, taking some of the work for them can be helpful, because as I mentioned, remember our 19-year-old is using every muscle in her chest cavity and every, her abdominal muscles and her supraclaviculars and her intercostals. Those muscles get tired, right? It's just like your legs get tired when you're going for a run. And as those muscles fatigue, that's when we start to worry about respiratory failure. So one thing that CPAP can do is bring some of the work off of the patient and onto the machine. So a benefit there. And then, yeah, bag them especially if they're really starting to slow down and tired out. And if you don't have CPAP, giving them some assistance with a bag valve mask provides, again, that similar positive pressure and then also additional respiratory support. All right, we talked about some of these, so get them out of the trigger, consider steroids. One thing that's kind of going to be a theme through some of the shortness of breath things that I'm covering is consider IV fluids if they're dehydrated. And I think it's really important to assess their fluid status. So we're not just we're gone are the days of everybody gets 2 large bore IVs and 2 bags of saline, right? We know that that's not actually helping a lot of our patients. But again, like running a marathon, if your asthmatic's been breathing at 30 times a minute for the past 4 hours, they've lost a ton of fluid. Look for signs of dehydration. Look for those dry mucous membranes. Look for some of that tacky tongue. Look for cracked lips, some of those signals that maybe your patient is under resuscitated and could benefit from some fluids, because that will help them kind of maintain where they need to be. And then if you're by yourself and you're far away, get it to the closest ER and then consider early activation of additional resources. Okay, so our patient got albuterol, they got steroids, they got mag, they got epi. She's on CPAP and she's tiring out. Now what? It's worth talking about. If you give a mouse a cookie, ketamine is a very interesting medication. It does a lot of good things. We won't talk about it too much here because it's not really in pre-hospital protocols for standard 911 responses. It is, however, the preferred induction agent. If you've activated a helicopter, likely they will use this medication to induce the patient for intubation if they need to intubate the patient. Why ketamine instead of a bunch of our other medications? Well, it's those smooth muscles again. So ketamine does actually cause smooth muscle relaxation and bronchodilation in and of itself. That being said, we would use it to facilitate intubation. We don't use ketamine to treat asthma. So while it does have smooth muscle relaxation, it wouldn't in and of itself be a medication we would use to treat asthma. At the end of our algorithm, we're in trouble. This is where none of us want to be. We know that critically ill patients that have asthma, when they get intubated, are critically ill, and also we're not going to do a good job with the ventilator to keep up with their crazy pathophysiology. So usually we are not going to take this leap unless we are intubating for some reason other than the lungs, because the ventilator is going to make them worse before it makes them better. Why would we intubate an asthmatic? If they have complete respiratory arrest, if they have severe bradypnea, so the respiratory rate has slowed down to 3, 4, 5, if they become severely altered or severely hypercapnic, so that end title, that CO2 level is through the roof, then we would talk about intubating them. But this is an almost never event. I don't know, Steve, did you make it back on? Can you hear me again?
Yeah, I'm
Cool.
good.
Have you ever
I,
intubated an asthmatic?
I have in flight,
How'd it go?
in preparation for the helicopter. We preemptively intubated several times earlier on in my career and learned that that's a really scary thing to do.
Yeah.
And with the ventilator in our lap and made literally respiratory cycle by respiratory cycle changes to try and stay ahead of it,
Yep.
and couldn't. It literally couldn't.
Yeah.
I mean, you wind up burping them multiple times because they stack, their pressure drops, their sats drop. Oh God, we have to evacuate the air out of the chest and start over. Um, the one thing that did kind of help in that bridge was is part of our protocol. If we were intubating an asthmatic patient, we were mandated to do continuous albuterol nebs through the
Yep.
vent to drive the medication down to the end bronchial.
Yep.
It kind of helped, but
Sure.
it certainly was it was scary. But
Yeah.
putting them in the airplane where you got room to work on them, we weren't as aggressive with it. Putting them in a helicopter where it's nearly impossible to intubate somebody, we did that preemptively and learned that maybe we should.
Yep. Yep. So lots of times people will be like, oh, just go ahead and intubate, just go ahead and secure the airway for transport, just get ahead of it. And especially when you're transferring an interfacility from a critical access hospital to, a larger facility, people are like, oh, just intubate before transport, intubate before transport. And I will agree with that statement 99% of the time. The 1% of the time I will not agree with that statement is in an asthmatic. Because again, ventilating them will often do more harm than good. You can see here that the obstructive strategy for mechanical ventilation is extremely complex. It gets wild, it gets weird. You have to like push on their chest to get them to exhale. So things, if you do have to intubate somebody, expect air trapping. You're going to be trapping a ton of air because you're now in a positive pressure mode. You're going to anticipate barotrauma. So sometimes these patients get 2 chest tubes because as soon as you switch to positive pressure, because all that air is just filling up in their lungs pop and you're putting in chest tubes. You have to get full exhalation, watch your waveforms, minimize PEEP, and prepare to burp, as Steve mentioned, chest tubes, and then like pushing on the chest to manually get the air out. But help is far away, and you're thinking to yourself, yeah, but we only have so many tools in our toolbox. This is a critically ill patient. They're very, very sick. So what are we going to do when we're at a long transport times, or when we have a long interfacility transport ahead of us, a long IFT, or the hospital's a ways away? So we do have our extended care treatment protocols that exist. And we're continuing to build these out, but just kind of looking at some of the mainstays of this is that continuous monitoring, reassessment, preventing hypotension. So doing what you can, knowing that if you've done everything you can to fix the airway, kind of moving to circulation, right? Like making sure that your hemodynamics are optimized, making sure that you're optimizing the entire cardiovascular system by giving fluids or resuscitating your patient so that you can at least try to support their innate ability to try to maintain their own physiology. And then consider additional resources very, very early on. These patients can change quickly. Their status can change very quickly. So these are constant reassessment patients. You may have to pivot from your original treatment plan or go back to the beginning, start back at the beginning of your ABCs. You may have to repeat doses of those mainstays of treatment. You won't need to repeat Solumedrol, but you may very well need, what on earth is happening tonight? There was a problem with PowerPoint. We apologize for your inconvenience. Okay. Thank you.
Windows.
Thank you very much. So you may need to repeat your albuterol. You may need to call online med direction if you are at the end of what you can give based on standing orders. And slideshow. Current slide. Oh, what a struggle. Okay. Share screen.
Are you using a Mac?
I am, and it is just
See, that's a
not,
problem.
but that's the problem.
Yeah.
Yeah, PowerPoint and my Mac are not friends right now. So what we're gonna do is go here, slideshow, current slide. Okay, there we go. Can you see it?
Looks good.
Okie doke, great. So we're reassessing. You may need to call med control for some out of the box ideas, and you may need some early additional support, getting that flight team, getting that critical care rendezvous and things like that, coming sooner rather than later. All right, questions? Anything in the chat?
Nope, we're good there.
Great. All right, case number 2. We're not going to spend as much on this one because we've really covered a lot of some of the big concepts, but it's still an out problem. This is a very common reason to be calling 911, obviously. So case number 2 is a 78-year-old male calling with shortness of breath. Their airways intact, diminished at the bases, some faint wheezing, increased respiratory effort, cool, wet extremities. Your history that you get after talking to this patient is that they've had worsening shortness of breath, some leg swelling, some coughing, history of CHF on Lasix, and COPD on home oxygen. I lost my presenter view, so I'm looking at it's a surprise for me which slide comes up next too. So he looks unwell. He's in moderate distress, alert, but anxious because he can't breathe. For those of you that have seen people that are truly suffering from respiratory distress, anxiety is not anxiety how we think of it. Anxiety is their body's kind of panic mode because they're unable to get oxygen to their vital organs. And he's got bilateral wheezing, decreased breath sounds noted, especially at the bases, but it is symmetric and everything else is overall okay. So here's your vitals. He's tachycardic. He's got fast atrial fibrillation. Not surprising in this 78-year-old man who has the other medical problems that we've listed. Blood pressure is okay. Pulse ox is 88. Temp is 36.8. And tidal is 50. I'll take this moment to dispel a myth because we have all probably been taught that there's this idea of the hypoxic respiratory drive that exists in our COPDers, meaning whatever you do, don't get them to 100% of oxygen saturation because then they're going to stop breathing. It is true that COPDers are often driven by a hypoxic respiratory drive and are more determined what their respiratory status is going to be by their CO2 than their oxygen. However, the concept that if we give them too much oxygen, they're just going to stop breathing and die is probably been oversold in our medical education and is a very much more of a theoretical concern than a practical concern. Our patient's allergic to penicillin. He takes medications every day, has COPD and heart failure. So here we are again in the lower airways. And here we are again with the same picture. And the reason that that is there is because, like I said, pretty similar pathophysiologies, but not exactly the same. So both asthma and COPD are obstructive lower airway diseases. So they're both an out problem. COPD is divided into emphysema and chronic bronchitis. Oh, that did not picture well. And many of you have probably seen some sort of image like this, or at least had to memorize the difference between the pink puffer and the blue bloater, and which one is emphysema and which one is chronic bronchitis. The reality is it doesn't actually matter when you're in the field and you're just trying to take care of the patient. So memorize that to pass your tests and your research, and then promptly forget it and recognize that there's a difference between an in problem and an out problem, and asthma and COPD are out problems, and we're going to treat them in a very similar way. Clinical signs and symptoms of a COPD exacerbation. A lot of patients that have COPD are very familiar with the fact that they have COPD, and they will say, I am having a COPD exacerbation, or they will say, my cough is increased. Yes, I always cough, but it's a lot worse. My mucus is usually yellow, now it's green. I usually only have a little bit of mucus, now I have a lot of mucus. All of those things are going to clue you in that they're having a COPD exacerbation. They've had history of similar, they have this worsening shortness of breath, increased work of breathing, and then have all of the things that we mentioned that our patient has. All right. Are you kidding me? Steve, I quit.
Again?
Now my internet just Chrome went down, which is fun, which is how I was using it. Restore. Okay, I'm just gonna keep talking, guys, and then I'll work on getting some slides up. So COPD is, again, mainstays of treatment are very similar to those that I just harped on for asthma, and that we're looking at duonebs, so duonebs being that beta agonist and inhaled anticholinergic. So it's going to be albuterol and ipratropium. Steroids, everybody feels better after steroids. Non-invasive positive pressure ventilation again. So remember how I mentioned that most of the studies that were done in non-invasive positive pressure ventilation were actually done in patients with COPD. And so keeping that in mind as a earlier mainstay of treatment for our patients that have COPD. Okay. And just before I do that, and considering other etiologies. So a lot of times patients with COPD are older, and when they're older, they have multiple other comorbidities. So remember, this patient that we just talked about had not only COPD, but also had CHF. So keeping in mind that we may need to be tackling some other problems in addition to those mainstays of treatment for COPD. All right, any questions on that? Okay, seeing and hearing none. Our patient is still wheezing. My goodness, 3 for 3 of our patients are wheezing. Well, here we go again. This is a 56-year-old female calling with shortness of breath, has an intact airway, but again, audible wheezing, accessory muscle use, and is pale, cool, and diaphoretic. Some additional history for her: she's allergic to penicillin. She takes lisinopril, calcitriol, furosemide, that's Lasix, and bicarb tablets. Has a history of end-stage renal disease, type 2 diabetes, and anemia. So she doesn't look well. She's pale and fatigued, has JVD, mucous membranes are pale. You hear bilateral wheezing and crackles and decreased air movement in both lung fields. So you hear it all. Everything's decreased, but when you do hear a breath sound, there's wheezing and there's crackles, and you're trying to like figure out which one of the things that you're listening to, but then you realize you're just hearing all of them at once. Heart sounds are muffled and distant. So when you try to listen to the heart, it sounds like it's far away. And you double check your stethoscope and you tap on it and you put it back on the chest and it still sounds far away. The abdomen is soft, and then she's got peripheral edema, which is worse in the lower extremities, and delayed cap refill. Of course, all of our patients here on this talk are going to be critically ill. Here are our vital signs. She's also in fast AFib. She's also a little bit hypoxic, increased respiratory rate at 32. Respiratory rate is a often forgotten vital sign. It's a very, very important vital sign. And it is a vital sign that can show us before any of these other things will show us that something bad is going to happen. So here we are, even smaller, down into the smaller airways. And again, do we hear wheezing? Do we hear rales? Do we hear both? This is just a moment to highlight the importance of your physical exam, because it really can help you differentiate between some of the things that we've talked about tonight. So what's next in this patient? Well, we've listened and we hear rales and we hear wheezing, and she has this history of end-stage renal disease. So again, thinking about in problems versus out problem, at this point, we can determine that she probably has an in problem. And what happens in pulmonary edema? So pulmonary edema is when you get fluid into the alveoli. The fluid can also go beyond the alveoli. It can kind of back up into some of the larger airways as well. And it can be classified in multiple different ways. And most of the time we think of pulmonary edema as being cardiogenic and non-cardiogenic. So your pulmonary edema is because of something with the heart, or it's because of something besides the heart. Not that helpful, but cardiogenic is going to be a high pressure pulmonary edema, and often we will hear wheezing. Non-cardiogenic is a high permeability. This means there's leaky parts of the lung tissue where fluid is going where it's not supposed to go. So the permeability is allowing fluid to get into those little tiny airways, whereas in cardiogenic, it's getting there just because the pressures are so high. Want to spend a minute on non-cardiogenic pulmonary edema. So this is not the heart's fault primarily. Can be seen in patients that have end-stage renal disease or dialysis patients. It can be seen in patients with aspiration, so they've inhaled something. It can be seen in drowning patients, toxic inhalation, and then ARDS. ARDS is mostly a hospital problem and is something that we typically have to fix on a ventilator. But keeping in mind from the 911 and pre-hospital standpoint, ESRD and dialysis patients especially, really high risk for non-cardiogenic pulmonary edema. Why is that? Well, it's actually for a lot of reasons. And the easiest thing to think about is that your kidneys are responsible for filtering the fluid that's running through your body, all your blood flow, right? And they're your fluid managers for the most part. That's why they make your pee, so you pee out the fluid because we got to manage that liquid. And so if we think about those not working at their most basic function, if they stop doing that, you can imagine that you're going to have a fluid problem. But it's a little more complicated and even happens for multiple more reasons than just the fluid problem. So over time, you kind of get this essentially high output heart failure. So often patients that have chronic fluid overload from renal disease will also have left and right heart failure and pulmonary hypertension, which is going to make you prone to pulmonary edema. There's all sorts of things that happen within the renin-angiotensin and other endocrine axes that make you more likely to have pulmonary edema. You're chronic, kind of in a chronic inflammation state in the setting of end-stage renal disease or in our dialysis dependent patients. So as you're living in these kind of chronic inflammatory states, you get capillary permeability. Again, you get the little holes in the walls where there shouldn't be holes, allowing fluids to leak out and around. You can get fistula. You don't get fistulas. Your fistula that you have for dialysis is rerouting of your blood flow. So it makes your heart work harder. So that contributes to your heart failure over time. And then, of course, you have electrolyte dysfunctions. And if the electrolyte balance in your plasma isn't exactly what it should be, then fluid's going to move into places that it's not supposed to move into. So a lot of information there, but basically just wanted to kind of highlight there are a lot of reasons that patients that have renal disease can get pulmonary edema. I think, of course, most of us think of pulmonary edema when we think about CHF or congestive heart failure. And again, as the heart starts to not do a good job of pushing fluid forward, that fluid gets backed up. And one of the places that it gets backed up is into the lungs. And that's what this diagram is just demonstrating here. What does pulmonary edema look like? Well, this is a chest x-ray where we can see no edema and then edema. And what we're looking at here is the lungs should have this kind of nice light gray look to them when we're looking at a chest x-ray. Those are the airways. That's all the places that air is and that air should be. We see the blood vessels along here. These are the ribs. The alveolar edema picture here, you see where this is nice and gray. This is white and has what we call a fluffy appearance to it. And that's all fluid where fluid shouldn't be. So pulmonary edema on x-ray just really showing us how it fills up where we would want air to be. So we have an air problem and we have an air in problem for pulmonary edema. There are other signs that your patient is fluid overloaded, including peripheral edema. So, depending on if you've got left or right-sided heart failure or renal disease, the fluid can back up into their legs or into their stomach. And then you can get JVD, that jugular venous distension. So this occurs not because of what I talked about before, which is that increased intrathoracic pressure, increased air pressure in the chest, but this is actually showing you the backup of fluid because the heart can't push it forward, so it just starts going backwards. Why do patients with pulmonary edema wheeze? Well, it's that common saying, not all wheezes are asthma, or a concept of a cardiac wheeze. Well, what's happening is you have a narrowed airway because of the fluid itself, or because the fluid in the alveoli and in the airways is irritating to that airway. The airway doesn't like it when fluid's in there. It's supposed to have air in there, so it gets frustrated when there's fluid in there. And so that act in and of itself can actually cause some component of bronchospasm. Remember to think about other things. Again, keeping your differentials broad, but you want to do a 12 lead to make sure that they don't have something that is causing acute heart failure, meaning their heart didn't fail just today. It's more of a chronic issue. So looking for STEMIs or rhythm problems. And then what do we do with these patients? Give them some oxygen, CPAP, if they're not ventilating or oxygenating appropriately. For patients that have a heart failure exacerbation, for our ALS providers, you can give nitroglycerin, which is going to help essentially reduce preload and reduce afterload. So it's easier for the heart to work and do its job because it's working against lower pressures. And then at the hospital, we're going to diurese patients. Some agencies actually have Lasix on board. Lasix is to CHF what steroids are to COPD. They're helpful, but you're not going to see the benefit in the back of your ambulance. Me again, CPAP, BiPAP, does it work? Probably. Probably helps in pulmonary edema, but the answer lies in this question. Which of the following is not one of the ways that CPAP works? So it's a little bit of a looking for the negative there. So A, forces interstitial fluid into pulmonary circulation. B, makes negative pressure. C, opens collapsed alveoli. Or D, pushes more oxygen across the alveolar membrane. I don't know if anyone's feeling brave. Throw in the chat. Which is not one of the ways. And some A's and B's. And the answer there is B. So the way that it doesn't work is by creating a negative pressure, and that's because it's positive pressure. And these are the other answers that were there, and this is how CPAP does work. And in the context of pulmonary edema, that positive pressure is shoving the fluid out of the alveoli and back to where it is supposed to go. So in pulmonary edema, this is, don't worry, we're just going to talk about the big picture here. So this is an alveoli, the white circle around here. Don't worry about all these other, don't worry about COVID over there, getting ready to attack it. What the blue circle around is this pulmonary edema. And what this is showing you is there are little spaces between the cells in the alveoli. And so if those spaces get too big, fluid can go from the vascular space into the alveoli, into the airway space, and vice versa. So when pulmonary edema happens, fluid's moving into the alveoli, and what we're trying to do with the CPAP is push it back out with positive pressure and with kind of forcing things through. So with CPAP, we're switching from a negative pressure system. Remember, normally when we breathe in, we are creating a negative pressure system and we're sucking air into the chest. When we breathe out, it's positive pressure. We're switching that when we are dealing with CPAP by creating a positive pressure system. So CPAP over here on the left is putting positive pressure in during inhalation and keeping that positive pressure going in during exhalation. I don't know if anyone's ever been on CPAP. It's actually quite uncomfortable. People equate it to kind of like sticking your head out the window while you're going down the highway at, 70 miles an hour. So you're trying to breathe in and out, but the machine is just constantly forcing air into your lungs, and it can be quite uncomfortable. BiPAP is a different level, bi-level, so you're changing how much pressure you're delivering on the inhalation and the exhalation phase. But both of these systems are delivering positive pressure in what is normally a negative pressure system. So again, help is far away. I just want to drive this home, fluid status evaluation. So especially in your patients with a history of heart failure, with a history of end-stage renal disease, if they've missed their dialysis. You really need to be incorporating fluid status into your physical exam. So looking for that edema in the lower extremities, listening for those crackles or those rails, listening for that wheeze, looking at mucous membranes. So really looking at fluid status. Heart failure and dialysis patients can get dehydrated. So you have to be looking at whether their fluid status is neutral, if they're fluid up, or if they're fluid down. And then start non-invasive early if you suspect pulmonary edema. Think a few steps ahead. So pulmonary edema patients, again, Lasix and diuretics are only things that are going to occur in the hospital. So if you can't get those things going and you're 45 minutes in the hospital, then start setting yourself up for success early, get them on CPAP early, get them bagged if they're tolerating it early, because the definitive care for these patients is dialysis or heavy hitting medications in an ICU. Pre-oxygenate them, get them on high flow O2, and then if you have it in your scope and in your protocols, diuretics and nitroglycerin. All right. This is my last case, and then I turn it over to the good Steve Rydquist. I'm sure you guys are tired of hearing my voice. We'll be refreshing to hear a new person talking. But here we have a 73-year-old who is calling with shortness of breath. Again, all these patients tonight, shortness of breath, weird. Primary survey is intact. She's got diminished breath sounds on the left, and she is pale, cool, and diaphoretic. Here's our additional history. Allergies to penicillin and sulfa drugs. Medications are letrozole, Lasix, and Ativan as needed for anxiety. Past medical history is triple negative breast cancer, COPD, anxiety, depression, coronary artery disease, and hypertension. So our vital signs on this patient, she's mildly tachycardic. She is hypotensive, and vital is okay. Pulse ox is 96, and her temperature is normal. And where are we now? So I tried to draw this myself, but we're actually outside the lung tissue itself. We are going to be in the pleural space. So pleural effusions. Pleural effusions are another thing that can cause shortness of breath. And what's happening in a pleural effusion is, so we talked about pulmonary edema, right? When we think about pulmonary edema, the fluid is accumulating in the alveoli. The fluid's accumulating where the air should be. In a pleural effusion, the fluid is accumulating where there should be nothing. So not air and not fluid. There should be nothing. There should just be this nice little space. This is like my second to last slide, so I don't even think I'm going to try to restore it. I'm just going to talk about pleural fluids first, or pleural effusions for a second. So the fluid is accumulating through the visceral and the parietal pleura. And so similar to what we think of with a hemothorax or a pneumothorax, where that fluid is building up between those two tissue layers, the same thing can happen in a pleural effusion where it's just fluid. It's not blood and it's not air, but it's fluid. Patients that are particularly at risk for this are patients that have some malignancies, specifically breast cancer, metastatic disease, liver cancer, and liver dysfunction. And renal dysfunction can lead to this fluid accumulating in between those two layers of pleura. And in doing so, it pushes on the lung tissue itself and makes the amount of lung tissue that's able to exchange air less. So it kind of causes that lung to collapse, just as we see in a pneumothorax and in a hemothorax. What do we need to do for these patients in the pre-hospital space? So these patients it's very uncommon, but they can get tension physiology from a pleural effusion. So just like you would see with a pneumothorax or a hemothorax, you can get so much buildup of pressure that it causes the blood pressure to drop and the patient to become very sick. I say it's very uncommon because pleural effusions are usually very slow and gradual in their buildup. So whereas a pneumothorax happens just like that, the air accumulates quickly, blood pressures drop. Pleural effusions often accumulate over days or even weeks. And so usually your body is able to compensate, and usually you don't see that tension physiology with pleural effusions. A needle decompression will not be helpful in a patient with a pleural effusion. A chest tube or finger thoracostomy might be if it is within your scope. So what can we do? Again, optimize their fluid status. So I know that they've got extra fluid in their lung surrounding their lungs, but that might mean that it's not in the alveoli, or sorry, that it's not in the vasculature where it should be, right? It's not in the alveoli, but it's not in the blood vessels, so they may need some fluids. You can transport these patients in a position of comfort. And I think this is something that we often forget to do. So sometimes the patient, if they lay on the affected side down, you're using gravity to keep that fluid down and allowing air to oxygenate the parts of the lung that are working. So let the patient lie on their side. Let the patient lie in a way that allows their body to maximize gas exchange. We're so commonly going to put these patients on the cot, put their buckles on and lay them flat, or lay the, or do a little bit, a head up a little bit and transport them that way. That can sometimes be catastrophic to their ability to oxygenate. So let the patient lie in a position of comfort. If it's sitting straight up, let them sit straight up, right? O2 supplementation, and then pain control. Pleural effusions can be very, very, very uncomfortable and very painful because that fluid is irritating that space between the pleura. So making sure that we're treating our patient's pain is a very important thing to do as well. Okay. I have a recap slide for my parts, but I'll just read them to you guys. Non-invasive positive pressure ventilation is probably useful in a lot of different causes of shortness of breath. Not everything that wheezes is asthma or COPD. Know if something is an in problem, an out problem, an air problem, or a blood problem. And think outside the box when your transport times are long. So think about positioning, think about different medications you can give, think about calling early and often. Frequent reassessments in these patients is essential. Any respiratory patient needs to be monitored very, very, very closely because they can change very quickly. And fluid status in that, with respiratory complaints, we get really fixated on A and B. Don't forget about C, because fluid status and optimizing fluid status can really help our patients maximize their overall cardiovascular well-being and decrease the likelihood of arrest. All right, that is my section of the talk. Steve, I think I talked for about as long as I said I was going to. I'm happy to answer any questions, and then I'm going to turn over screen sharing to Steve once I promote him to a panelist. If anyone wants to take a few second break while we get our slides switched over, obviously more than welcome to. And Steve, I think I have allowed you to share if you want to give it a try.
Looks like maybe possibly. Let's see what happens here. How's that?
Looks good to me. Looks better than mine did. Fingers crossed for your success with your slides.
I'm trying to get something else figured out here real quick.
Okay.
What did I do?
It looks good for a second there.
Stand by.
Yes, Graham County. I'm so glad you guys asked that question. Yes, pulmonary edema can be caused by vaping. So vaping is very irritating to the lung tissue itself. And we've actually seen some cases of flash pulmonary edema from vaping. And it's thought to be not only because of the chemicals, but because of the heat. So those vape pens can actually get really, really hot. And people that are vaping can set their kind of preferred heat status. And if they get really, really hot, you're essentially inhaling hot smoke, as you would in a fire, or another, bad situation, which can cause that increased permeability, like we talked about, essentially poking holes and allowing fluid to move from the vascular space into the alveoli. So it causes a really fast, really intense inflammatory reaction, increases permeability of the membrane, and can lead to pulmonary edema.
All right, well, here we go. We got about another 40 minutes. Angie got she got the easy stuff. I got the hard stuff, right? So we talked about non-infectious causes. Now we're going to talk about some infectious causes. In realistically, in total, what we've learned over the last hour absolutely applies to every pathology that we're going to talk about. Okay. So case 5, here we go. You are called to the home of a 72-year-old female with general weakness. You arrive on scene to find her sitting slumped on the couch, leaning forward, appearing limp. Her airway's intact. She has audible rhonchi coming in the door, without any noticed obvious increased work of breathing. So junk lung sounds, and you look at her and you don't think they should be junky. She's slightly tachycardic and has a strong peripheral pulse. And she's like, yeah, I'm kind of breathing okay. So again, what's next? What are you thinking based upon your initial assessment? Is she sick or not sick? And go ahead, and we can even come off mute or in the chat and have kind of some chat here. What do you think's next? I think we lost them. They're typing fast.
The wheels are turning, I can tell.
Uh-oh, I just lost you again.
We can hear you.
Physical exam. All right. And she's sick. All right. How about some vital signs? Got a heart rate of 102, a respiratory rate of 22, a room air sat of 76%, an end-tidal CO2 of 32, a temp of 38 or 100.4 Fahrenheit. Her pupils are pearl, but it's shade sluggish, and a Glasgow coma score of 15. Her skin is hot, pink, and dry. Any other considerations? Good. No, she is not diabetic. Phenomenal. What else? Keep them coming. So what do you think about her current vital signs? Yeah, end-tidal CO2 of 32, and there's the waveform there on the screen. It's really kind of a good waveform. Got a good alveolar plateau phase. Looks really pretty good. Good. I like where you're going. Well, we know that this is a lower bronchial, bronchi, even alveolar stuff, right? Because if we look at her vital signs, she's trying to compensate with a heart rate of 22. She's a bit tachypnic, but not overtly so. No increased work of breathing. Her saturations are kind of junk, right? And her end title's a little bit down, and she's fevered. Okay, so we're going to place this in the lower respiratory tract. Physical exam. She appears slightly somnolent. I mean, if you look at grandma sitting there like that, she's looking at you going, who the hell are you and what do you want? So little to no increased work of breathing. She's had a periodic cough, no pedal edema or JVD noted. Does that change your differential at all? What are you thinking about? Deb asked for lung sound. They hear pretty much. They auscultate pretty much what you hear. Ronca, they sound kind of junky, but no real wheezes, and she's moving pretty good air. There's a pneumonia. How long has she been sick? That's a very, very good question. Been feverish for the last 2 days. She complains of a quote unquote little chest cold that began this morning. She's no energy for about 2 days. Got a past medical history of hypertension and GERD. Cough has not been productive. What are you thinking? I got pneumonia. What else? I got COVID. I got bronchitis. Let me ask you this, Susan. What do you say COVID? What would trip you to say COVID specific stuff? Lower lung, no productive cough. Think back to our vital signs too. Um, she's hypoxemic, right? But she doesn't look hypoxemic. I mean, her respiratory rate's up a shade. She's got a fever. You remember back in the days of COVID where we talked about happy hypoxia? That's what grandma looks like, right? You wouldn't expect her to have pulse oximetry in the 70s based upon the look of that picture, right? She's alert. She's a bit sluggish. She's tired, but her oxygen is in the tank. Remember that COVID and a lot of other stuff is really that lower airway disease. And Andy says, is it a problem getting air in, getting air out? Not necessarily, right? It's not really a problem to get air in or air out, but what the problem is the oxygen transferring across the alveolar capillary membrane to be into the circulatory system and then circulated around. So it's an oxygen diffusion problem, and not a whole lot that we can do in the field for oxygen diffusion problems. We'll talk about a couple of things here in a little bit. Um, I feel as a provider that we lived so much COVID for so long that we're kind of into what I call COVID fatigue, right? We don't even want to think about COVID anymore. And in all reality, the severity of the illness, the typical variants that we see now, we don't see an across the board severity like we did in the Delta variant and even before. Um, would you use PPE with this patient? Would you think about that? Are you still going to every call masked up? Because most of us aren't. This call came in as a generalized weakness. I mean, we get 7 of those calls a week, right? We have a high elderly population. We get called to that all the time. It's like, all right, going to grandma's house. So not typically. We've kind of gotten mask fatigue. We've kind of gotten PPE fatigue. But walking into this really suggests to me that we need to do some sort of PPE. And we'll talk about that here in just a little bit. So what are our care priorities for this lady right here, right now? List them out for me, please. Use your chat. O2. Okay. What else? What else are you thinking? IV. Okay. You going to give her fluids? Let's go back and see what her history was here. Just hypertension and GERD. Are you gonna give her fluids, optimize her fluid status? She's had a fever for 2 days, cough, sick, general malaise. Might give her a little fluid. Obviously, the number one thing that we need to do with grandma is get her on some oxygen, get her saturations up. They may or may not respond real well with that oxygen, depending upon how much that alveolar capillary membranes broke down, how much the alveolar space is full of stuff, how much atelectasis does she have, right? Marissa says look and treat for sepsis. Does she meet sepsis guidelines? Got a heart rate of 102, a respiratory rate of 22, a sat of 76, and a level of consciousness of 15. I think 2 out of 3 ain't bad, right? How about inhaled beta 2s with her? What's her blood pressure right now? Oh, it's 144/58. How about albuterol? Would you give Granny albuterol? If I needed to, right? She's got junky breath sounds that are audible. Maybe you hear a wheeze when you lay your stethoscope on her chest. Maybe you look at your end tidal CO2 waveform and it becomes shark fin like. That alveolar plateau part of the waveform becomes narrowed, right? Maybe she has increased work of breathing at that point in time. Maybe she doesn't look so happy hypoxic. So, yeah, absolutely. CPAP, if I put her on oxygen, if I put her on high flow oxygen, so greater than 10, and I don't get her oxygenation up, I'm absolutely going to consider driving that just a little bit. But I'd also be a little cautious with that, right? Watch her blood pressure. Make sure that she has enough blood pressure to support that invasive, non-invasive positive pressure, and a steroid. So Angie, maybe you can kick in on the steroid here, because historically we have gone with the signs of infection, general malaise, don't feel good, and the big one being fever as being a contraindication for the use of steroids. I know you mentioned some a little earlier, but maybe you can kind of kick in on that a little bit.
Yeah, I mean, I think it's tricky, and steroids have traditionally been taught as immunosuppressors, right? So they're going to make it so that your immune system isn't working as well, which kind of goes against what we want to be doing in someone who has an infection. It's like, well, why would we give them a medication that's going to make it so that their immune system doesn't work? But in sepsis and in bad COVID and in some of these other processes that we're going to talk about, the inflammatory process that has happened because of that infection has gone haywire, which is why patients are as sick as they are. Your immune system should follow a pretty strict little pathway to fight the infection. but those pathways don't always stay on track. And when they go off the rails is when we start seeing the big inflammatory cascades, the ARDS, the bad lung stuff, the hypotension. And so that's when we start thinking of steroids helping, because it's decreasing the inappropriate immune response that we see with some of these sickest patients.
I like that. I like that a lot. Steroids certainly could be beneficial in this. And like Andy said earlier, a single dose of steroids in the critical phase of illness is going to do squat for the infective process. I mean, the concern with giving steroids to an infective process is that you'll make that the infection fulminate. Probably not going to happen. They're going to have some benefit from it, right? So let's go back a year, hell, even a year ago, where we were talking about COVID. We were so scared about the cross contamination, the cross exposure of it, that we're like, oh my God, we can't do any aerosol generating procedures, right? So anything. I mean, we're worried about suction. We're worried about naps. We're worried about hell. We were worried about just normal respiration. Remember that back in the early side of it, when we thought about cardiac arrest and we were intubating under shower curtains, I'm glad that went away. I'm glad that we can treat our patients. We can absolutely and should absolutely treat our patients appropriately nowadays. Now, does that say that we shouldn't consider PPE? No, absolutely not. Especially when we're thinking about aerosol generating procedures of giving them nebulized breathing treatments, intubating, suctioning, realistically in the back of the ambulance in a closed space. We should probably have PPE on. And so kind of generally, we talked early on about source control of the patient. I think that's still appropriate, right? I don't really want to get COVID again. I've had it one too many times. Kind of sucks. It's a man cold now, but when that changes, we don't know. So I'm going to protect myself. I'm going to protect my patient. I'm going to go ahead and mask up. If I'm doing aerosol generating procedures, I apologize, I can't talk. I'm probably going to up my PPE just a shade. I'm probably going to go to a minimum of an N95 or a P100 mask, using an eye shield or some eye covering, and maybe even a gown at that point in time, because it still increases the risk. I'm absolutely going to source control the patient and put a surgical mask on them. Right? Questions about that? Deb said IV. I absolutely agree. I mean, this patient's been sick for a couple of days. She's been febrile for a couple of days. I want to ask her about her history of urination. Is it normal? Is she going normal amount, normal number of times a day? But I'm going to go ahead and start an IV and probably try and optimize her intravascular volume. The other thing to think about, she's got a really big fever, doesn't she? If you carry antipyretic medications, whether it's PO Tylenol, whether it's ibuprofen, whether it's Ofirmev, the IV Tylenol formulation, think about that. And of course, analgesia, depending upon if they're hurting, right? But don't ever forget about analgesia. She may be getting tired, right? She's been sitting on a couch for a couple of days. Maybe she needs a little analgesia. And always, always, always remember, as these patients get sick, this patient here is the one that's sitting there looking at you one minute, and all 10 toes up the next minute, right? So think about pressors as well. We have to maintain that blood pressure to get oxygen to the cells and carbon dioxide to the lungs and being expired. So again, that is as needed. That is based upon that specific patient, that specific time.
Steve,
Questions about the
for the PPE part. And I think why we actually picked this topic for January was because we are in respiratory season. So the things that I talked about and the things that you're going to talk about, with whether it's COVID or pneumonia or flu or whatever it is, if a patient's chief complaint is shortness of breath or a cough, I'm putting a mask on. I don't want flu, I don't want COVID, I don't want RSV, I don't want any of it. And the just regular mask is quite effective from a flu and RSV standpoint too. So I know we're tired of it and we hate it, but it does help. We're also seeing weird outbreaks of shingles and meningitis and all of these things. So just another plug.
Yeah, absolutely. The outbreak of meningitis really kind of has me a shade concerned, right? That's not something that we've seen over the past decade. That's a whole different subject. All right, questions about the COVID case. I'm tired of old people. I'm tired of adults. So on to case 6. You're called to a local grocery store for about a 2-year-old female not breathing well. You arrive on scene. Your primary assessment, you find them in the checking line in the mother's, oh my God, I can't even type there, in the arms of a panicked mother is what that should say. Because I read baby can't breathe and lost all my stuff. All right. Airways intact. You hear an audible stridor with significant work of breathing and retractions and nasal flaring. The kid is tachycardic with a central capillary refill of 2 seconds and a peripheral capillary refill, maybe a little bit more. What do you think here? Sick or not sick? Rapid transport, sick. Well, when I walk into this and I see the panic mom, I'm okay with the panic mom because they get that way. But when I see the baby that looks like what this sounds like, you're going to hear kind of this. That's my rectal sphincter slamming shut. We got a sick baby here. We got to go to work, right? So what's next? Well, let's look at a picture. There's your retractions. We got a heart rate of 132, a respiratory rate of 38, a room air saturation of 86%, a temperature of 40 or 104 Fahrenheit. Pupils are pearl. Maybe they're a little sluggish, but they're good. Child appears to be 4, 5, 6 for 15 and hot, flush, dry skin, right? Would you say that that this kid is in a form of respiratory insufficiency? Do we need to act right now? Yes. This baby's going to the back of my ambulance, and while I'm on the way to my ambulance, I'm going to be trying to remember all the really big signs of respiratory insufficiency, right? The big ones being grunting, head bobbing, and drooling. I don't like those in peds. Those to me are a sign of impending respiratory failure. Granted, this kid's tachypnic. This kid is failing right now currently because he's failing to maintain his oxygen saturation. Okay. Physical findings of this. You find a kid limp in the mother's arms with increased work of breathing, obvious retractions. He is painfully hot to the touch, and you notice urinary incontinence. Does that change your opinion at all? Mine either. Historically, mom reports 2 days of fever, decreased fluid intake for about a day, a harsh cough with a really runny nose for about 2 days, with this just all of a sudden at the store acute onset of distress right now. What are your differentials here, guys? Crew? Okay. What else? Keep them coming. RSV? Okay. Keep them coming. Come on, somebody say it. COVID. Pneumonia? Epiglottitis. We'll talk a little bit about that in the differentials here in a little bit. Um, the uh, the historical findings and also the physical findings of either ruling in or ruling out-ish of epiglottitis. Okay. Abscesses, that's very good. I like where you're going with this, right? So bronchiolitis or RSV, is really kind of a problem with us, both currently and this is kind of the time of the year, right? If we look at what's happening physiologically with bronchiolitis, so bronchiolitis, it's inflammation in the bronchioles. Okay, I like that. Drooling tells your brain epiglottitis. I like that. So what happens in RSV? It's typically a disease of the lower airway tract, right? Respiratory syncytial virus. And what happens? We get thick, tenacious sputum that forms in our lower airways, even down into the alveolus. We'll get some mucus plugging with that. We'll get atelectasis with that. Those airways become thickened. We can even see some necrosis later on with that. More specifically in the kids, I mean, their little bronchioles don't have the ability, the real estate, to accommodate for both the swelling and the spasm that goes along with it. So this is an example of our current protocol, and it's based upon age of the patient, right? So less than 2 years, we kind of think bronchiolitis. Greater than 2 years, we think more of asthma. So this kid's right at that 2 years mark. I did something kind of naughty, right? I said 2 years because that puts it kind of right in the middle. So does an asthmatic who's having an exacerbation have a temperature of 104? Probably not. Does an asthmatic have typically a runny nose? All the phlegm and sputum and secretions associated? Probably not. I think we can safely put this into that waterfall list of bronchiolitis being the most common, right? Most important interventions that we can provide is supplemental oxygen and suction the secretions. Okay. So we're not talking deep tracheal suctioning, but anything that you see, anything that's coughed up needs to come out. Okay. Oxygen to obtain saturations of greater than 90%. Okay. So how are we going to deliver oxygen to this little tyke? What are we going to do? You're going to put a cannula on? How about a mask? How do we know which one to choose? Blow by? Yeah, I'll take that. I typically try and keep my hands free. I like appliances. I may go with a mask or a cannula on this, and we know that the kid really needs it if he takes it, right? And then if I can't do that, then I'll typically go to a blow by. I need my hands free for other stuff, right? I'm gonna I'm going to start an IV on this kid. Is this kid volume optimized? With 2 days of fever, 2 days of cough, now this acute exacerbation? Absolutely not, right? We think about the amount of secretions in the bronchioles that are getting dried out because we have an elevated respiratory rate, right? They're getting tenacious. They come tenacious. Now the patients that are not volume optimized, they don't have enough liquids to really help with those fluids. This kid's probably going to get an IV and a 10 mil per kilo bolus. Okay. Nasal suctioning, especially if you've got a bulb syringe and either little bullets. You can get saline bullets that come. They look like just like one of our albuterol, or most of us have IV flushes in our ambulances. Squirt about 3 cc's into each side of the nares and get them suctioned out. Obviously, we're going to monitor SpO2, respiratory rate, the retractions. What are we going to do for pharmaceutical therapy? What does this kid need? Do we need inhaled beta 2s? Is there spasm associated with this? A neb treatment? Okay, I'll take that. What are you going to use? Albuterol, Atrovent? Both? Does it matter? I don't really typically like Atrovent in this patient because of the amount of secretions that are developed in the bronchioles, right? Atrovent, as it's atropine-like, it has a drying effect of the secretions that are already nice and thick. Okay. You're right. I love it, James. You're at the store. Run back to the pharmacy and grab some children's Tylenol. Kid needs some. I like it. Okay. Is this going to be a BLS or an ALS airway? The question. BLS airways preferred in pediatrics, like every time, right? Even at a critical care level, I'm probably not going to RSI this kid and attempt intubation. How about non-invasive positive pressure, either CPAP or BiPAP, whatever you have? What are you thinking about that with this? Yes or no?
Depends on how mad it makes him.
That's it. Exactly. You know when to use it? When they take it. Right? Oh, no for kids. And level of consciousness. So what in the level of consciousness would say that it was contraindicated? It's kind of somnolent. He's a little limp, but he's alert and looking around. Is a child of 2 years of age a contraindication for non-invasive positive pressure?
Depends on the agency.
Bingo. Might not be allowed by your protocols. It's not a true contraindication. I mean, the one thing that you also have to watch and you have to think about, right, is when we're talking non-invasive positive pressure, BiPAP or CPAP, if you're holding the mask, it's one thing. If you're putting the mask on with straps, it's a different thing, right? Even for that patient who may be a little somnolent, right? Maybe that's what they need to get them respiring again. And a trial of handheld non-invasive positive pressure maybe isn't contraindicated. Maybe that's something you call a doc and talk about, right? That outside of the box stuff. It's obviously a really sick patient to go down that pathway. But don't, are you in agreement with that, Angie?
Yeah. Yep.
Okay. Kind of figured you were. All right. RSV by age, because anybody can get RSV. Everybody gets RSV. Adults get RSV, and that is the man cold on steroids. It's not a comfortable thing to go through. It's not typically life-threatening unless we have other comorbidities, other diseases that go along with that. But it really can be life-threatening in vulnerable populations, infants and children, and the elderly. And notice that realistically, it's the same problems in both age sets, right? Um, Infants and children can develop bronchitis from it. So it's bronchiolitis, right? So it typically begins affecting the lower airways, the lower of the lower airways. And as that infection, as that mucus production, as that tissue destruction moves up the airways, now we have bronchitis as well. Typically, there's enough phlegm and not enough pulmonary toilet, not enough air moving through, that will get consolidations and pneumonias. Obviously, fever is a symptom of it, but controlling the fever, secondary to controlling the intravascular volume, right? I mean, kids don't do real well with prolonged fevers because they're probably already just they're human. They're already a little bit dehydrated anyway, right? And of course, the wheezing and respiratory distress. The the elderly, um, obviously aggravating pre-existing respiratory ailments, pre-existing cardiovascular ailments, pre-existing old age ailments. Um, and then we have to think too on the elderly side is what medications do they take, right? Do we blunt their compensatory mechanisms uh, in the ability to compensate for injury or illness by some of the medications we give them? The beta blockers, the calcium channel blockers, the ACE inhibitors, right? Do they already have underlying pulmonary disease of COPD or chronic bronchitis? That's what makes them so frail by nature. Um, and then the big question is it RSV or COVID-19? So the CDC puts out some really good things. I really like my little chicken and egg little meme thing up there. That I thought that was kind of cool. Um, what's the difference between RSV and COVID-19?
Doesn't matter.
Does it make? There's exactly where I was going. Does it matter? No. Each one of these pathologies are essentially treated symptomatically, right? We have to get down and figure out what the problem is, where the problem is. Is it air moving in? Is it air moving out? Or is it blood going around and around? And fix and optimize each side of those equations, regardless of what we're talking about, regardless of what pathology we're talking about. It's treat the symptoms. All of this is symptomatic treatment. So let's go back. Do we give steroids to this patient? Would we give steroids to this type of patient if they were adult? Is there a pediatric dosage for methylprednisolone or solumedrol or decadron if you carry that? Think about the outside the box clinical reasonings for doing some of the things that we do, for doing everything that we do. And if it's not in your protocol, it doesn't mean that you physically can't do it. It means that you need to talk to somebody about doing it. Okay. I am going to put up the QR code in case people want to leave. And we're going to talk very briefly about the differential of RSV, croup, and epiglottitis. What big differentials, what big signs or symptoms do you guys look for in epiglottitis? The book would say an acute onset of a severe fever, a massive sore throat, inability to control secretions, and drooling, right? How does the treatment change between anything that we've talked about tonight and epiglottitis?
I can take that one.
You do her.
I think one of the things that we're traditionally taught and that remains true when we're talking about upper airway swelling, so epiglottitis or tracheitis or some of these other more honestly more severe pathologies that we think of in kids, is that if you've gotten to the point with that upper airway that it is so swollen that you're hearing stridor, that you're having drooling, that you're having some of these other objective findings, less becomes more. And so, yeah, don't irritate it. And some of the comments that have been put in the chat. So with a lot of the lower airway stuff, we're talking about pretty aggressive early interventions. And with epiglottitis, tracheitis, it's a no touchy sort of a situation, and it's a less is more, because you are teetering on such a fine balance of worsening the problem with agitation, that you actually want to just kind of sit back and make balloon animals with your gloves and drive. Now, if it's so critical that airway management is absolutely necessary, then you have to do what you have to do. But the upper airway swelling is a more hands-off and much less aggressive from an intervention standpoint, is what I would say. I don't know if you agree, Steve.
Absolutely. If I'm thinking epiglottitis, I'm not doing nothing but a diesel bolus. I don't want that kid to cry. I don't want that kid to do anything, because the risk is that massively swollen epiglottis goes into a spasm, and now it's over. I I can't lift that even in an unconscious state with a laryngoscope. I'm probably not going to be able to get a tube past that.
And you
And in
can't
the
crank a kid, so.
that was the next thing I was going to say. Can't crank
Oh, we're
a kid,
just so aligned.
right? My goodness. Yeah. So I don't like epiglottitis. In all honesty, in 30 plus years, I've only had two suspected cases and one known case, and that was an adult, and I still didn't like that.
I will say,
So
and I want to give the folks on this call the confidence to do the things you need to do. I think so much of the rhetoric around peds is like they're scary, and they are scary. Like there's a reason that I only work at the grown-up hospital. I only have to see kids
man,
when they walk in the wrong door. I'm like, you didn't see the balloon animals? It's like right across the street. Um, but have the confidence to know that kids are bouncy and they are resilient, and so they will pull through a lot of these things without much intervention from us. And I think that additionally, just knowing that things like epiglottitis and tracheitis and like Steve mentioned, while we learn about them so much because we need to know about them, they're very, very, very rare. And when they do happen, it's not subtle. So it would be very uncommon for you to get QI feedback on like you know, hey, you transported us this kid and completely missed the fact that they had epiglottitis. I don't suspect that that is ever the case because these are not subtle presentations. It's not like a hidden STEMI or something masquerading as something else. These are pretty clear. These kids look incredibly sick, and it is not a sneaky or subtle process.
No, that's in your face, right? Absolutely in your face. Any
Awesome.
questions? None at all.
I'm going to
Either we did
stop
a
the
good
recording.
job or a horrible job.